Hello and welcome to Connected Conference 2025. My name is Lisa Schaefer and I'm the Executive Director here at Obesity Canada, and we are thrilled that you've been able to make time to join us this week. This year, we're trying something new for our Connected Conference. Our sessions are designed to be on demand and flexible so that you can watch them at your convenience. We want to allow you time so you can absorb new insights and reflect on how they might apply to you and your community. But we're not stopping there. We're also trying something new, and we're hoping that on Friday, March 7th, you will join us for a live roundtable discussion where we're going to bring together experts, advocates, and you, our incredible community, to connect, to collaborate, and inspire some real action on obesity care in Canada. In the spirit of building connections, I also want to encourage you to join OC Connect, our private online peer support community, where you can engage with others who have similar experiences and insights. I also want to make mention that you have the real opportunity to help us shape the future of obesity care in Canada and what Obesity Canada looks like. We are having a stakeholder survey available to the public until March 7th, and your voice is essential in truly implementing meaningful change. And meaningful change is needed because we know that obesity isn't just one person's challenge, it's all of ours. This complex chronic disease that's influenced by biology and environments and the systems that we live in for too long has been misunderstood. It has been simplified and it has been stigmatized. And that's why we're here. And that's what we're trying to do. We want to shift the conversations. We want to take everybody from judgment to understanding, from outdated stereotypes to science-backed solutions, and from isolation to action. We know powerful change comes from making connections. When research meets action, when education inspires change, and when advocacy amplifies voices, we truly transform lives. This isn't a simple journey, but it is one worth taking. Change happens when we come together and use our collective voice. So across 2025 and beyond, you will see Obesity Canada calling on policymakers, healthcare providers, and everyday Canadians to join us, to challenge the bias, to break down barriers, and to rewrite the narrative of obesity in Canada. With our collective courage, I truly believe that we can build a Canada where health is not defined by size, but rather the freedom to thrive. These are important conversations, and again, we are thrilled that you are here to join us. I also want to thank our generous sponsors who have made the event possible this year, but really, thank you for being part of Connected 2025, and thank you for believing that better is possible. Let's go make this amazing.
Hi, everyone. It's an honor to deliver this message to you today at Obesity Canada's Connected Conference 2025 on World Obesity Day. As healthcare professionals and individuals personally impacted by obesity and diabetes, you understand better than most the complexities of these conditions. The staggering 3 in 10 Canadians living with diabetes or prediabetes, and 1 in 3 adults grappling with obesity, the urgency for effective solutions has never been greater. This need is amplified when we think an estimated 80 to 90% of people living with type 2 diabetes also experience overweight or obesity. Navigating a new diagnosis, managing an existing condition, and meeting the demands of everyday life can be challenging for patients living with obesity or diabetes. But you don't have to face it alone. Your pharmacist is a key part of your journey and care team, offering support beyond just medications. Pharmacists can provide personalized and evidence-based diabetes advice, check A1C and cholesterol levels if required, and help you navigate your diabetes management plan with confidence. Pharmacists are here to give you the knowledge and support you need. At Shoppers, we see the impact every day. A simple blood pressure check or an A1C test at the pharmacy, sparking vital conversations and leading to early interventions and improved outcomes. That's why we are heavily invested in research, partnerships, and equipping our clinicians with the tools and resources they need to deliver the highest quality care and help patients achieve the best health outcomes. Forums like this are imperative for driving meaningful change in obesity and diabetes care. Today, we will hear from experts and patients about navigating these complex conditions and how we can expand access to care and treatment. Let's continue to work together, share our expertise, and advocate for better access to diabetes and obesity care for all Canadians.
Hello, and welcome to Obesity Canada's annual public virtual conference, Connected 2025. This year, the theme is It's Bigger Than Obesity, Connecting the Dots in Obesity Management. We know that obesity is a complex chronic disease, but we also know that it's one that doesn't often happen in a silo. It is connected to a number of other health conditions. We wanted Connected to focus on some of the intersections that happen with obesity management. So today, that intersection is diabetes and obesity. With today's discussion titled Dealing with Diabesity, Successful Management of Obesity and Diabetes. This session of Connected is brought to you in partnership with Diabetes Canada and Diabetes Action Canada. We would also like to take a moment to thank our sponsors for this conference who have made this possible. A big thank you to Shoppers Drug Mart, Pfizer, Novo Nordisk, Boehringer Ingelheim, and Johnson & Johnson. Connected is our annual public conference for World Obesity Day. You can find the archives of previous conference recordings on the Obesity Canada YouTube page. This year, we're spreading the virtual conference over the course of a full week. Each day, we have a new keynote session released here in the virtual venue that you can watch on demand. So make sure you're coming back each day to check out what's new by clicking on the on-demand video section. In the lobby, you'll find valuable information about our sponsors and speakers. Discover the sponsors who make this week's conference possible and explore details about our speakers, including their bios. On Friday, March 7th, we're going to wrap up the week with a live roundtable discussion featuring Dr. Sokolingam, Dr. Proder, Lisa Schaefer, and Ian Patton. This dynamic conversation will take place at noon Eastern Time and will provide insights on how we can all take action to be a part of the shifting tides in obesity management. Throughout this week, if you have any questions that come up, please either make note of them and bring them to Friday's live roundtable discussion, or you can send your questions directly to ian@obesitycanada.ca. We're going to do our very best to answer as much as we can. My name is Lauren Gates, and I'm a non-healthcare professional living in Calgary, Alberta, and a member of the OC Connect community. It's both an honor and a pleasure to be your host for today's conference. With a personal connection to obesity, my goal is to bridge the gap between patient lived experience and professional practice, fostering a more compassionate healthcare environment. I hope that the conversations that we have this week will inspire greater empathy, deeper understanding, and more effective patient care, while providing education and support to those impacted by the complex chronic disease of obesity and its related conditions. Okay, so now on to today's topic, obesity and diabetes. With us for this discussion, we have Dr. Rishi Handa and pharmacist Khalid Bhatti from the Durham Care Clinic, along with Linxi Mytkolli from Diabetes Action Canada, to help us better understand chronic disease management in the context of obesity and diabetes. Dr. Rishi Handa is an internal medicine specialist and medical director at Durham Care Clinic and Pharmacy. He also leads the Durham Care Diabetes Education Program and Handa Medicine Research, focusing on diabetes care, weight management, and cardiology. Dr. Handa is a collaborating physician at multiple diabetes education centers and a principal investigator at Centricity Research, leading studies on cardiometabolic disorders. Khalid Bhatti is a pharmacist, certified diabetes educator, and advocate for improving care for people living with diabetes and obesity. As Director of Pharmacy and Director of Education at Durham Care, he focuses on patient-centered care, medication optimization, and education. He also serves as Chief Scientific Officer for the MELT Method, an evidence-based approach to weight management. A nationally recognized speaker, Khalid is committed to bridging gaps in healthcare and empowering patients through knowledge and innovation. Linxi Mytkolli is a passionate advocate for patient-centered care and the Director of Patient Engagement at Diabetes Action Canada. She leads initiatives that ensure patient voices are at the heart of healthcare innovation, including the Research to Action Fellowship. Linxi played a key role in shaping Canada's first national framework for diabetes and led the creation of the DAC Hub, the world's first directory of diabetes resources and organizations. She is a recognized speaker at global forums, driving conversations on health equity and patient-driven change. So welcome all, and thank you for joining us today.
Thanks so much, Lauren. Okay, so as I mentioned at the top, this is a very important topic, and as the title of the episode suggests, knowledge is power. So we hope we can help raise awareness so more people can be empowered to manage their obesity and diabetes. I would love it if we could start with each of you just telling us a little bit about the work you do and what got you interested in this space. So Rishi, let's start with you.
So I started my journey a few years back, managing my private clinic and it started off in Oshawa, Ontario. And one of the things that we had noticed was there was a gap where we were able to offer very good diabetes care, but it was very haphazard. I was the physician, and patients were going for education in different centers. So that it was one of the reasons why Khalid and myself we decided to create the Durham Care Diabetes Clinic, where we offered physician oversight along with multiple diabetes educators, and had a patient-centric approach for diabetes care.
Awesome. So Khalid, over to you. What do you do, and just a little bit about what you do and what got you interested in this space?
Yeah, thank you. So I'm a pharmacist by background, and I'm also a certified diabetes educator. As Dr. Honda was saying, a few years ago, we decided to collaborate and put together a clinic where patients are really at the center of care, and that's both for diabetes and patients living with obesity, so that they can have a collaborative approach and really feel that they're part of a healthcare team with pharmacists and educators, physicians, dietitians, fitness coaches, and the list goes on, so that we can really bring the same level of care that diabetes patients would get to patients living with obesity as well.
Awesome. And Lindsay, over to you. Can you tell us a little bit about what you do and what got you interested as well?
Absolutely. So my full-time job is managing my diabetes, and then my day job is patient engagement at Diabetes Action Canada. So a few years back, I was diagnosed with diabetes and became a patient partner with DAC to grieve my own diagnosis. I was looking for community and connection and the acceptance that I struggled to get in the healthcare system, trying to get that through other folks that lived with diabetes that could relate to me. And I just never left. So since then, I've joined the Diabetes Action Canada team. And in my current role, I look to create processes and programs to connect people with lived and loved experience with diabetes and those with learned and labored experience to co-design solutions that improve the quality of life of those living with diabetes every day.
I love it. So you took your pain and you turned it into rocket fuel. That's awesome. Okay, so I think most people recognize that obesity and diabetes are closely connected, although I'm not really sure we all understand what that means exactly. So perhaps a good place to start is Rishi and Khalid, if you could please talk a little bit about what exactly is diabetes, what's happening in the body, and what are some early signs and symptoms?
Sure. So diabetes is, I'll explain it the way I explain it to my patients, is it's when an individual has difficulty with managing blood sugars. So I really break it down very simply to patients that, once food is consumed, the food is broken down in our gastro GI system, and then our blood sugar goes up. And normally, what ends up happening is we have our pancreas, which is an organ. One of its many functions is to help with regulating blood sugar by producing a hormone that moves the blood sugar out of the sugar out of the bloodstream into cells. And so individuals with diabetes have difficulty with doing that. Either they have type 1 diabetes, which I further explain to patients that is a lack or a very low level of insulin that's present in their body, and they need to use exogenous or outside sources of insulin to help regulate their blood sugars. Or an individual with type 2 diabetes has something called insulin resistance, where the insulin that they're producing may have difficulty with working due to various factors, and there exist many different things. One of the things that can help majorly is lifestyle changes, and I go on and explain what that is: exercise, diet, and we also explain how the various different medications work to help with that as well. And the interesting part is with our patient population, we have patients that are living with obesity, overweight, and we, focus on, explaining to patients that weight is just not a number. It can impact the way that the individual's body's functioning. And one of the ways that this can impact someone is by creating insulin resistance. And we try to do a good job explaining how various medications can help, various lifestyle changes can help, and just provide the patients with as many resources as possible.
Fantastic. Is there anything else either of you would add to explaining kind of what is diabetes, what's happening in the body?
I think that's a pretty good summarization of diabetes.
Awesome. Okay. So now I'm curious about how are diabetes, you've alluded to it a little bit, but how are diabetes and obesity related? And how common is that intersection appearing in your practice? Khalid, let's start with you.
I think it's certainly growing. I would say the number of patients that are living with the intersection of both. Um, there's certainly some overlap that we see now in terms of pharmacotherapy as well. Some medications, Ozempic, Mounjaro, to name a few. These medications were started to be used by patients with diabetes, and now are also being used for patients living with obesity as well. So you're certainly seeing a lot of overlap. So it's important that the level of care that patients get when they're facing diabetes, that same level of care is really important for patients living with obesity as well.
Mm. Rishi, are you seeing a lot of overlap as well in your practice, and what's notable to you?
I am. Yeah, a lot of the times, because of the relationships we have with other physicians in the area, we do pick up on diabetes quite early for patients. We're focusing on type 2 diabetes or insulin resistance. We have a lot of gynecologists, OBGYNs that we work with. So gestational diabetes is something that, we do see as well. We are seeing more and more, patients that are diagnosed with overweight and obesity at a younger age. And unfortunately, these patients do end up developing insulin resistance and later developing diabetes. But the nice thing, that we're noticing now is that Khalid had mentioned, once upon a time, medications for diabetes basically resulted in, weight gain, unfortunately, to manage diabetes. And there was very few medications that had helped with weight loss, or at least keeping the weight stable for patients. And now we have many, many different options available for patients. So it's a very exciting time to be in this space, both for physicians and for patients and for educators.
Amazing. So Linxi, you're probably seeing a lot of people in your community with the overlap as well. I'm curious, can you talk a little bit about your community for diabetes and how often you're seeing these co-occurring conditions discussed together? And how is obesity viewed in general by people living with diabetes from your perspective?
I often like to tell people that when we step out in the Canadian winter, we don't step out with just a hat or just mitts or just a coat. You put everything on and you leave the house. And the reality is that same analogy is true for our identities. We don't get to leave our diabetes at home and step out with our obesity, or vice versa. So we're seeing a lot of folks come to the community that might wear a hat, mitts, and a coat. They might live with diabetes and obesity and mental health and. And most people come to community to find belonging, acceptance, and then resources and support. The reality that I have seen a lot, and we see a lot in our work, is unfortunately, and a bittersweet truth, what tends to bring our communities together is a shared struggle with stigma. It's really interesting because the diabetes community has really welcomed folks with lived experience of obesity over the past several years on this connection of, I wish our diseases weren't moralized. And that point of connection can really be powerful, because for a lot of folks, when you deal with such stigmatizing experiences in the system for years, it takes an interaction like that where you can finally feel safe and trustworthy again, to then start asking questions of, are there things that I can do to be better, to be happier, to be whatever it is that my goal is? That we see that happening in community a lot, actually. One advocate or one patient saying to another, I see you, I understand you, now let's work together.
Absolutely. Yeah, I'm seeing a lot of, commonality with the obesity community as well. I mean, we always talk about how weight is not a behavior. Obesity is a disease, just like diabetes is. And the shame can really be a problem, and stigma. Yeah, I'm glad we're talking about this today. Okay, so Rishi and Khalid, as healthcare professionals specializing in obesity and diabetes management, you probably see degrees of this hesitation or defensiveness around healthcare from your patients. So, like healthcare avoidance or being nervous to speak up because of this stigma that we just talked about. So, how do you approach someone who may have had some negative experiences in the past with healthcare? How do you positively influence them in order to get some care? And how do you go about maybe rebuilding some trust that may have been broken, in order for them to actively engage in their disease management?
I think, unfortunately, as we've all kind of alluded to a little bit, when it comes to patients and navigating our healthcare system, especially, more so, unfortunately, when it comes to obesity, but also with diabetes as well, they've had experiences where they may have gone to see physicians or healthcare providers and heard things and saw things that would really discourage them from turning to healthcare again, right? And so we're all, working together on rebuilding that trust with all of those patients, the whole community. And I think, the important thing is that they know that it's a safe, open space to talk about things. Unfortunately, we've all heard it, eat less, move more. That's what people would be told, and we're trying to shift away from that, and really just create an open dialogue with patients and let them know, this is a safe place. If you want to talk about weight, if you want to talk about your diabetes, your eating habits, your lifestyle, exercise, whatever it may be, so that they feel comfortable. And it's only when patients feel comfortable, that relationship can be reestablished. Once that relationship is started to be reestablished, then they'll feel comfortable with some of the things that you may offer them, right? In terms of seeking out dietitian or cognitive behavioral therapy or pharmacotherapy. But it's really important to first establish that relationship, make sure patients feel comfortable, and small things, right? Like, for example, in our clinic, we have bariatric chairs in our waiting room. They don't have armrests on the side, so people of all different sizes and shapes can feel comfortable in the chairs, right? We've got scales that won't stop at a certain weight, right? And it's just making the patient feel comfortable, starting from there, and then hopefully you can start to establish a long-term relationship with that patient.
Yeah,
We've made
awesome.
it, yeah, we've also made it a point to make it very easy to talk to us about it. A lot of the times, physicians that specialize in, obesity care, it's very difficult to get to them. There's a lot of resources now that are available, but we have patients that tell their family, friends, and family members, and Khalid and I talk about this all the time, where we're getting just chat messages on our websites about, how can I see this doctor, or I want to talk about my weight. Another way to help patients is by providing them with information as well. So we've tried to make as many tools available. So we have a lot of resources that we've created ourselves that gives the patients a reputable place where they can access this information. In this day and age, there's a lot of information but a lot of it is, it's not the best quality of information. So, everyone's doing their best by putting all this information out there. But what we've tried to do is have it available in a space where it's vetted by us, and we, make it as accessible as possible to patients.
Yeah, help to cut through the noise and make it easier. So Lindsay, not to put you on the spot, but I'm curious. What are some of your thoughts on this? And also, have you heard any really good examples recently in your community of when these conversations went really, really right and what that looked like? I'd love to hear about it.
I have thoughts. Thank you for asking.
Amazing.
So, I have a few things I'd like to touch on. The first is I really encourage folks who work in this space, especially healthcare practitioners, to accept that anyone who lives with a chronic disease is constantly processing grief. And what I mean by that is we're processing grief on so many levels. First, there's the grief of we're all born and instilled with expectations about how our bodies should look, behave, and what they should do for us. And when you get diagnosed with a chronic illness, you're constantly processing the grief of, wait a sec, I didn't expect my body to do this. I expected something else. Then you're processing the grief of your expectations of the healthcare system and how it lets you down. You're processing the grief of you go to sit down on a bus chair and that bus chair lets you down. You process the grief of the comments that you hear at the grocery store, at the Thanksgiving table. The grief never ends. It's just we do a really good job of hiding it. And something magical happens when you sit in an office or you sit in any space with someone in the healthcare system and they see the grief and they make space for it and they allow it to just exist. So I really encourage folks to accept that people with chronic disease are always processing grief. The other thing I'd like to say is when we do patient engagement exercises at Diabetes Action Canada, I have a couple of very few rules, but 2 rules. One is we start every conversation with a question that has nothing to do about diabetes. And the other one is if it's a Zoom call, no creepy goodbyes. We always say goodbye verbally at the end of a call. And why is that important? Well, first, when you're managing a chronic illness, your whole life, every moment is consumed by some level of thinking about it. So when you sit down and your doctor says, how was your internship? Or how are your kids doing? Or, oh, you got new glasses. I remember the first time my doctor opened up my chart and she had written down that I was getting married. And she said, how was your wedding? And I started to answer about how my blood sugars were. And she said, no. Was it fun? Like, did you have a good time? What did you like? Did you dance, etc.? It really changes the power dynamic because now you are more than your disease. You are a human being first, then we'll talk about the condition. And ending the conversation on a human note is also so powerful because now the last thing in your mind is not about what I have to do better or what I have to do less of or how I feel crappy about myself. It's, oh, I'm a human first and a human last, and this is another human in front of me. It's not someone who's this big bad doctor. We're building a relationship. We're building trust. It's rare, but it's so powerful when that happens, and I have faith and trust that we'll see more and more of that in clinical settings.
Oh, I love that so much. We're all just people. We all grew up with the same diet culture rhetoric and blame and shame of weight and everything. And it's just like, let's all just meet each other as human beings first and then get into the nitty gritty later. But let the patient also lead the way, right? Like if I came in to talk about my sprained ankle, I probably want to talk about my sprained ankle and I might not want to talk about my weight. So yeah, I love what you're doing, Lindsay, and amazing points. Thank you so much. So knowing about this community. It's hard not to imagine that the people who show up in clinic for diabetes treatment are a little bit more comfortable or aware of treatments, or maybe they hit a tipping point that required them to bite the bullet and seek help. I'm not sure, I'm just imagining here. But what do you think needs to be done to help reach everyone else from our communities that might have that healthcare avoidance or might not know that there's help available? Like maybe they're experiencing some of these symptoms, they're concerned about their weight, they're concerned they may have diabetes, it runs in their family. What would you say to that? Maybe Rishi, let's start with you.
So I think the first place to start is just by, we have those of us that have family physicians, those of us that have, nurse practitioners, just making it a point to, having an exam. Where we live in a time where actually in Canada, it's very difficult to have primary care. And unfortunately, a lot of the times diabetes is diagnosed when things are going very, very bad for the patient. For example, they might end up in the hospital and they're there for a totally different reason, and all of a sudden someone says your blood sugars are 20 or something, and that's it. That's all that's basically told to them, and they're asked to go and follow up with their providers. So I think one of the if someone has the luxury, I should say, of having a family care provider, a nurse practitioner, making sure that you do have an annual exam, can go for blood work. It's a very easy diagnosis to make. It's a blood test. If you have doubts and you are very worried that your blood sugars are uncontrolled and you have family members with diabetes, for example, you can even just check your sugars yourself at home. You need the right tools, obviously, but it is something that can even be checked at home, for example. Unfortunately, there are signs of diabetes that can happen for patients. So an excessive, thirst, having to urinate, feeling dehydrated, even sometimes feeling very weak, and nausea. A lot of the times when patients have other illnesses going on, unfortunately, their blood sugars are also very erratic, and this could bring on a lot of other symptoms. But in order to diagnose, it's a very easy diagnosis, but you just need to go to the right place, and I guess in a setting where folks don't have a primary care provider, we do have walk-in clinics that are available. It's not the ideal situation because continuity of care is a major issue there. But in terms of diagnosing, it's fortunately a very easy diagnosis to make based on blood tests.
Absolutely. Khalid, what do you think needs to be done to help access, those in the communities that might not be aware that help is out there or aware of what to do, how to seek out help?
You know what? I think we live, in the information age, and most people have access to smartphones or the internet these days. So I think it's just, as simple as just meeting patients where they're at, and getting it out there to them, be it on Facebook or social media or commercials that and there's certainly some commercials I've seen on TV recently that are improving this a little bit, but just letting them know that, hey, you don't need to be afraid, you don't need to be worried, there is help out there, there are resources, and just kind of get them and direct them to those right resources, wherever they may be, online, video, getting them into different languages, different forms that patients can take in depending on what suits them best, to really start the conversation and the process of giving the autonomy back to the patient. As Dr. Handa said, unfortunately, there's a very large population of Canadians living without primary care. They may have barriers to finance or education or a whole host of things, language, and they just don't know where to go or where to start. And I think the onus is on us as healthcare providers, and members, in the community who work in this space to really get out to where the patients are at. No one should feel helpless or hopeless and not know what to do when they're concerned about something when it comes to their health.
Absolutely. And I think, Lindsay, you'll agree with me also. There's also the word of mouth aspect, right? Like in marketing, my background's marketing. You have a bad experience, you tell 7 to 20 people. You have a good experience, you tell a few people. But wouldn't it be great if every time somebody did seek help, whether it be through a pharmacy or ER visit or their GP or what have you, that it was a really good experience and that they could tell people about that, and then that would increase it as well. You have some thoughts, go ahead.
Yeah, I agree with you, Lauren. Word of mouth is really popular. And I was actually going to say, I'm going to challenge our beliefs a little bit. I think that we believe that folks need the answer to folks getting better access to care are actors in the healthcare system. So folks like healthcare practitioners. I'm actually going to flip that, and I think community is the missing ingredient in getting folks better access to care. I've spent more time before I had diabetes talking to my pharmacist and my friends about my health than any doctor, and I've been in the 1% of access. I've lived in urban settings. I have advanced degrees in science and healthcare. I have community members that have helped me. I still, even with diabetes, I reach out to my support groups much more than I've ever reached out to my care team. Now, why is that important? Because community can be an excellent conduit to getting people the care that they need and the access that they need. This ties really nicely to the trust aspect. The reality is that once one patient builds a trusting relationship with the clinic, with a pharmacist, with a doctor, that patient is going to be in a Facebook group, in a WhatsApp group, following an Instagram page. And now, if I'm struggling and I reach out to my friend can direct me to evidence-based resources, to a clinic, to safe care practices. And I think here, part of our job and our duty as the system to enable that kind of referral is to change our language a little bit about how we talk, especially about diabetes. We've had a really strong language matters movement in the diabetes space for the past about 15 years, but we still struggle with this a little bit because I always tell people, for example, if I could control my blood sugar, it would be 5.5, 100% of the time. I can't control it. I can do my best to manage it. So if I hear someone saying, well, Lindsay, you have horrible control, do better, I'm never going to tell my community to go there. That feels so shameful. And I also want to challenge another piece of our language, which is I actually think community is a big provider of health, not just healthcare practitioners. So I always tell people, there's healthcare practitioners, there's advocates, but we're all healthcare providers. We're providing health to each other in so many different ways. We just need to point each other to evidence-based solutions.
Mm-hmm. And wouldn't it be a beautiful thing if everyone in the world didn't have shame or judgment or stigma, and we all just supported each other in that way as well? Amazing. Okay, so we know obesity is a chronic disease, but we often hear about how it's treated as a secondary issue in the context of related conditions. So maybe we hear stories about doctors who want to treat the related condition first, for example. So in the case of obesity and diabetes, can you talk a little bit about why that's not the best approach and why we need to treat the conditions together concurrently when they present at the same time?
I think we now have the luxury of treating both conditions at the same time for a lot of patients. With available medications now, we can put both things at the center. When it comes to diabetes, we really want to get the blood sugars controlled, but it's just not the blood sugars at this point, right? It's the other conditions that are related to the diabetes as well, which it's the kidneys, it's the heart, but now we have the ability to put weight at the center of and make it the center of attention as well. A lot of the times when I have a patient sitting in front of me, I actually get referrals for patients that basically it just says, consider starting insulin for this patient, and we sit down with the patient, and they have this look in their on their face. They're like, oh my god, he's going to say it, insulin, and they've heard all the stories, and I find it, when you talk to a patient and you let them know of all the different options, all the medications that what they actually do, how they can help with controlling the sugars, but also metabolism and appetite and all these different things that are possible through medications. They're relieved. They're like they have a sense of hope that I'm not just going to be put on this medication that I just have to now continue to go up on, and that's it, game over for me. When they're given all the options and they're explained all their options properly, patients are really grateful. And when you put what is number one on their mind, and you make that number one for the both of you, I think patients really, really appreciate it. And that's when they start, you have to earn the respect from the patient, right? You can't demand respect from your patient. You have to respect your patient as well. But when you're listening to them, when you're, speaking the same language or on the same page, they are more willing and more open to listening to what you have to say, really.
Mm-hmm. And probably asking the questions that matter most to them as well.
Absolutely. And listening to them, right? Seeing what actually matters to them. Of course, to a physician, I want their numbers to be perfect. Numbers don't matter to patients as much as how they feel. They want to know that they're being heard, and we need to listen to them.
Mm-hmm. Absolutely. Khalid, what are your thoughts on that?
Yeah, no, absolutely. I think with diabetes and obesity, the interesting thing is that if we're able to control and manage some aspects of the obesity, and there's some weight reduction that we can achieve, however we try to achieve that, then those will reflect on their blood sugar numbers, right? Whereas with other conditions, maybe if we're focusing on, we're always focused as healthcare providers on the outcome, but we're not really looking at what got us there, right? So the intersection here, diabesity, what we're talking about today, if we flip it and we look at it starting with obesity, and we help the patient and we talk to the patient in whatever that may look like with weight management, then maybe we bring blood sugar more into manageable range. But then maybe we also improve other things and aspects of their life as well, right? There was a small study that was done, and a lot of healthcare providers don't talk about this, but diabetes remission. And it looked at a very, very reduced calorie diet for patients. Something that's very difficult to achieve, but they did it in this small population. And with a 900 calorie diet, patients were able to achieve diabetes remission. Now, that's not a realistic thing for everyone, but it just goes to show you that there's a whole spectrum of different things that are possible. And it's really, like Dr. Handa said, letting the patient know everything from A to Z and figuring out what works best for them, and working together to create a solution that's tailored for that individual patient.
I think that what you're alluding to a little bit, and I'd like your thoughts on it, is obesity being potentially an upstream condition, and obesity management being a treatment to prevent diabetes. So I think kind of we're touching on that a little bit. I'd love your thoughts.
Yeah, absolutely. It's you're starting to see it a lot more, especially in younger patients that are presenting with higher weights and with obesity. Those patients, if you were to follow them, most of them will go on to develop diabetes later on in life. And so if we can address the obesity earlier on or even at presentation, then they may be better able to manage other conditions, diabetes being one of them.
Mhm. Absolutely. Lindsay, do you have some thoughts?
Yeah, I just quickly want to touch on the remission piece before going back to your original question. I'm just mindful and cautious about how we speak about remission because the way I like to explain it to our patient partners is it's like changing the volume on your radio. The music is still playing, the radio is still on. But what we see in remission is that we've actually just lowered the volume of how that insulin resistance is showing up in your body. And the reason I think it's really important to explain that is because one of the reasons that mistrust of the healthcare system persists is because sometimes we don't do the best job of managing expectations with patients. We get what we're saying because we're speaking the same dialect. But I want to touch on what Rishi was saying, which is you have to speak the dialect that your patient is speaking. I always say in patient engagement, it's the job of a translator. You have to take the dialect of the patient and the dialect of the researcher and the dialect of the doctor and somehow craft a shared language. I think that's really critical in this work. Because often when you speak the dialect of your patient, what they'll say is that they want to play with their grandkid, or they want this internship, or they want to be able to do an exchange semester in Italy, or whatever it might be. They're not making the same trade offs as we are, diabetes or obesity first or second. And if we make them feel heard, most of the time we arrive at your conclusion, Lauren, which is obesity is upstream to diabetes often. So we don't need to start the conversation there, though. We start the conversation with, tell me about that exchange semester that you want to do. What's holding you back? How can I help you get there? And that's when the treatment decisions come into play.
Absolutely. Oh gosh. Okay. So it reminds me so much of what we talk about in the obesity community, which, a lot of people think, okay, I've taken this GLP-1 and I've lost the weight. So now I don't have the disease. You still have the disease. You will always have the disease, but the medication is helping your disease be under control. It's turning the volume down on that insulin resistance, on on those hunger cues, the food noise, and all of that stuff. But you have the disease, and that's okay. Like, it's okay to be managing your disease for a lifetime, just like you would be managing your diabetes for a lifetime, your high blood pressure for a lifetime. Like, it's all good. But just because we lose the weight doesn't mean we lose the disease. The volume's turned down. I love that analogy. That's super smart. Okay, so I'm wondering, does your approach differ for someone who's seeking diabetes management without the presence of obesity? And what are some of the common elements of obesity and diabetes management? So in your experience, I'm curious about like some of those keys to successful management of obesity and diabetes. It's a lot of questions. So maybe Khalid, let's start with you and you can cherry pick from that what you want to answer, and then we'll go over to you, Rishi.
Sure. So I think, as we've talked about, a lot of the pharmacotherapy, GLP-1s, are now in that shared space. They're used for both diabetes patients and obesity patients. So, that's something that is available and it's a great option for patients, if they choose to use that. In our clinic, we offer sort of a host of different things for patients, and it's really similar to the diabetes patients and the obesity patients. Of course, there's medications like GLP-1s. For obesity, there's also Contrave. But then we make available to all of our patients dietitians, fitness coaches, and cognitive behavioral therapy. Because it's not just about pharmacotherapy, right? There's a lot of patients that come to see us, and they the first thing they tell us is, what, I don't want a medication, right? And great. So we have a whole bunch of other options for them, right? There's some patients, now with information that's out there to everyone. And it's wonderful. It makes our jobs easier. They come in and they advocate for themselves, and they kind of tell us exactly what they want, right? Our job is to make sure that what they want is safe for them. It's the right fit. And we also give them, as Lindsay said, the right expectations for those things, right?
Yeah.
a GLP-1 is great, but there's, certain side effects that you need to know about, right? You're going to have some GI side effects. There is a little bit of muscle loss as well, in addition to the weight loss. It's not just fat. There's muscle, there's fat, there's a whole host of things going on, right? So we really need to make patients aware of that, set their expectations, let them know how to manage the side effects of these things, give them access to a care team. So if they do get any side effects or there's issues, they have someone to contact, have regular follow up with them, and then offer them all of those other services as well, so that they, if they choose, can speak to a dietitian, can talk to someone about certain exercises that maybe you should be doing when you're on a GLP-1 to maintain some of that muscle. Some patients, want to talk to a cognitive behavioral therapist about their relationship with food, right? And this applies to both the patients who are dealing with obesity and the patients who are dealing with diabetes, because it makes our job easier that it's sort of this a very similar type of treatment algorithm for both of them, right? As Dr. Honda was saying earlier, we work with a lot of diabetes education programs. We have our own diabetes education program, and one of the things that we're striving to do is create an obesity education program, right? Patients have access to certified diabetes educators, with almost every endo. All the hospitals have them, but it's very difficult to find somewhere to talk to someone specifically about your obesity. And so, that's something that we're really striving to do. And, just to make things easier for those patients and make them more comfortable in having these dialogues.
Mm. So Rishi, over to you. So I imagine your approach is similar to folks who have diabetes and obesity, or folks who just have the diabetes. Would you like to kind of talk a little bit about your approach and your thoughts on that?
Yeah, I mean, our approach for patients is it's very similar now. Once upon a time, I guess some physicians might have reserved the use of Ozempic and certain GLP-1 receptor medications for a certain patient population. But there's been so much research in this space, to the point where you have patients that have diabetic kidney disease, that don't have any weight. Their BMI or height to waist ratio is normal completely, but being on a GLP-1 receptor agonist now will benefit them from a renal perspective, from a kidney perspective, from a heart failure perspective. So, like I said, before all this data was available, we might have picked we pick and choose different things, but now we found that we don't have to distinguish between a patient that has, obesity and diabetes alone. We know that these medications benefit everybody. I do want to touch upon one thing. I think one of the most difficult patient populations to talk about someone's weight is that older man that comes in for their diabetes management. They don't necessarily, a lot of them, don't want to be generalizing here, but a lot of them don't really care about their weight, or will not prioritize their weight. But when you start explaining to patients that, I can, going over all the medications and explaining to them that, look, according to your blood tests, you need to be on a cholesterol lowering medication, your blood pressure's through the roof, but we can focus on helping with reducing your weight, and that can help minimize polytherapy. We can give endless number of pills to patients, but sometimes when we focus and explain to patients that by using certain types of medications, by implementing certain lifestyle changes, if we can help with your weight coming down, that's going to prevent us from needing to use all these other medications. Because what we fail to remember is that medications do have side effects, right? in clinical trials, we have tons of side effects that do happen. It's just a matter of how tolerable they are and how severe they are. But everyone's different. And a lot of the times, patients are weary and afraid of medications because of people having that community, and they know that, I was on this medication, this is what it did to me. And if a physician just haphazardly says, you're going to go on this medication now, it's going to really help you, but then, they don't really explain to the patient properly that these are the potential side effects. This is what you need to do if this happens. And then sort of says, I'll see you in 6 months, and not making themselves available, right? So something that we do in our clinic is that there's multiple touch points. I mentioned that chat function on our website. Patients use it for these types of things, but patients are encouraged to call us at any time. They can call the pharmacy, they can call my staff. Unlike a lot of other clinics, unfortunately, I don't know if many of you know this, but a lot of physician offices don't even have a voicemail, and you just keep on calling, and you can't even leave a voicemail or email. So one of the things that is very important to us at Durham Care is that patients need to have access to you, and you need to be there. If you've taken on their responsibility, you need to make it your responsibility to be there when they need you. So we try to make it as easy as possible to get a hold of us.
It's amazing. Yeah, probably easy to fax. It's like one of the only one of the only professions where we still fax. But anyway, sorry.
One point I just wanted to add. I think right now how we practice medicine is very reactive, and we wait until something is wrong to treat it. And hopefully where these conversations about obesity management are going to lead us is to a more proactive healthcare system. If we can be proactive in treating things when they start, before they start, then we can maybe prevent some things, not all, but we can prevent some things from starting or potentially getting worse, right? And I think that's really the shift that we need to have, and we need to take that approach. And that's something we've tried to implement into our practice with our patient population.
I'm going to jump in really quickly, Lauren, mostly because everything that Rishi said had me dreaming. First, no societal pressure on weight, then a doctor's office with an answering machine. That is so nice. I recently switched doctors, and I can email the clinic. It actually changed my life. I was like, this is amazing. We're best friends now. I'm going to text you all the time. But I think one thing I really want to say, which I think actually deserves its own separate conversation about how gender intersects with all of this, all jokes aside, sometimes I think we need to do a better job of probing on why folks don't want medication, and especially if you have women in your clinic, why they don't want medication. There is so much rhetoric around, if you take this medication, you're going to gain weight, or if you take that one, you're a failure, or if you take this one, this is great because now you're going to look just like the world wants you to look. And I think that deserves its own hour, but I'd be remiss if I didn't mention that we need to probe a little bit deeper there.
100%. So I still have pages of questions, so I think we're going to have a part 2. This has been super, super awesome and informative and amazing. A few key takeaways for me, for sure, are going to be, that weight is not a behavior. Diabetes is not a behavior. They are chronic diseases that deserve their own care and are often needed to be cared for concurrently. The more that we can treat the whole person and take it from a person first perspective and lean into community and try and dismantle some of the stigma, the better off we're all going to be. And that it's really important for us to make sure that we're creating welcoming spaces, whether those welcoming spaces are conversations or places like pharmacies or healthcare offices. It goes a long way to make people feel welcome and make people feel like they can open up and talk about what's going on with them. So thank you so much for joining us today, Rishi, Khalid, and Lindsay, and thanks to all of you who have taken the time to join this conversation. Again, we want to thank both Diabetes Action Canada and Diabetes Canada for partnering with us on this important session. So how do we keep this conversation going? Join us on OC Connect. By joining OC Connect, you'll instantly connect with others living with obesity at various stages of their journey. The platform also offers exclusive access to expert content from Canadian and global leaders in obesity, along with exciting live and virtual events designed to inform and empower. Make sure you come back for the live roundtable on Friday. That discussion is going to be awesome. And please check out our website at obesitycanada.ca.